Welcome back to Professor Dr. Muhammad Amir Memon official YouTube. Today, we will know about Patent Ductus Arteriosus, PDA. But before we proceed, if you are new on my channel, please do not forget to like, share, subscribe, and hit the bell icon for instant and regular updates. Let's start. Patent Ductus Arteriosus, or PDA, is a condition where a fetal blood vessel, the ductus arteriosus, fails to close after birth. This vessel normally connects the pulmonary artery to the descending aorta, allowing blood to bypass the lungs in utero. PDA accounts for approximately 10% of all congenital heart defects, occurring more commonly in females, with a 2-to-1 ratio. It is frequently seen in very low birth weight infants, especially those with pulmonary disease or congenital rubella. In full-term babies, persistent PDA rarely closes on its own, while in premature infants, spontaneous closure is more likely unless early treatment is necessary. In patent ductus arteriosus, if the ductus remains open after birth, blood flows abnormally from the aorta into the pulmonary artery, the lower pressure side, during both systole and diastole. This results in oxygenated blood being recirculated through the lungs and returned to the left side of the heart. Consequently, 1/2 to 2/3 of the left ventricular output may be shunted into the pulmonary circulation. This volume overload increases the workload of the left atrium and left ventricle, eventually leading to dilation and dysfunction. Over time, persistent shunting can result in pulmonary hypertension. The severity depends on ductus size and vascular resistance. The clinical findings in patent ductus arteriosus largely depend on the size of the ductus and the direction of blood flow. In cases where the PDA is small, there are usually no noticeable symptoms. However, a large PDA with significant left-to-right shunting can lead to symptoms of congestive heart failure, especially in infants. These may include breathlessness during feeding, poor weight gain, and frequent lower respiratory tract infections. Even a small shunt can severely compromise very low birth weight infants, particularly those with underlying pulmonary disease. On physical examination, if the shunt is small, peripheral pulses are typically normal. In contrast, a large PDA may cause bounding pulses and wide pulse pressure due to excessive runoff into the pulmonary circulation. The heart may appear normal in size with a small ductus, but becomes moderately or grossly enlarged with a larger one. A prominent apical impulse may be felt, which can be heaving in the presence of cardiac enlargement. A systolic-diastolic thrill may be palpable at the second left intercostal space. Auscultation reveals a loud pulmonary component of the second heart sound, P2, along with a characteristic continuous machinery murmur in the pulmonary area. If pulmonary hypertension develops, the diastolic component of the murmur may disappear. In the diagnosis of patent ductus arteriosus, a chest X-ray plays a crucial role. The heart size, pulmonary vascularity, and the size of the left atrium and left ventricle all reflect the extent of the left-to-right shunt. In small PDAs, the chest X-ray may appear normal. However, in large PDAs, there is clear cardiomegaly, left heart enlargement, prominent pulmonary vascular markings, and a double right heart border indicating left atrial enlargement. Echocardiography is a key tool in diagnosing patent ductus arteriosus. In cases of a small PDA, the echocardiogram may appear normal. However, when the ductus is large and the shunt significant, there is noticeable enlargement of the left atrium and left ventricle. The patent ductus itself can often be directly visualized through the suprasternal notch using color Doppler imaging. Medical management of patent ductus arteriosus in preterm infants often involves pharmacological closure using indomethacin or ibuprofen. Indomethacin is administered intravenously at a dose of 0.2 mg per kilogram every 8 to 12 hours for 3 doses. The ductus typically closes after the first dose. However, its use is contraindicated in cases of elevated serum creatinine, thrombocytopenia, active bleeding, necrotizing enterocolitis, or sepsis. Surgical management of patent ductus arteriosus is recommended for all non-preterm infants, regardless of age. In cases of small PDA, closure is advised to prevent complications such as infective endocarditis. For moderate to large PDAs, surgical closure is essential to avoid congestive heart failure and the development of pulmonary vascular disease. The preferred method is ligation and division of the ductus, ideally performed before the age of 1 in asymptomatic patients. Notably, pulmonary hypertension is not considered a contraindication for surgery at any age. The prognosis for patients with a small patent ductus arteriosus is generally good, and many can lead normal lives with minimal or no cardiac symptoms. However, spontaneous closure of the ductus beyond infancy is extremely rare, making medical or surgical intervention important. If left untreated, PDA can lead to serious complications, including congestive heart failure, especially in larger shunts. There is also a significant risk of infective endocarditis and the development of pulmonary hypertension, which in severe cases may progress to Eisenmenger syndrome, a life-threatening condition. If you missed any part of today's lecture, don't worry. You can catch up by watching the complete video anytime on my official YouTube channel. Thank you for watching.